Hello, and thank you for joining our webinar today entitled How to Navigate Proposed Changes on Substance Abuse Records. My name is Rick Reifenbark, and I'm a partner in Foley's Los Angeles office and a member of Foley's Digital Health Group. I'm joined today by two speakers. Leeann Habte is Senior Counsel and Digital Health Lawyer with Foley and Lardner. She is also a Certified Information Privacy Professional. She advises a broad range of clients, including health information exchanges, providers on privacy laws related to HIPAA, substance abuse disorders, and mental health. She also provides regulatory advice on compliance with privacy and security laws, breach reporting, and new data sharing arrangements and models. I'm also joined by Jennifer Lohse. Jennifer is the General Counsel at Hazelden Betty Ford Foundation. She joined the organization in 2014, and her responsibilities include oversight of legal, risk management, standards and compliance, and the privacy departments. Today's webinar will last 30 minutes. To the extent that we don't make it through all of the slides in our 30 minutes, please feel free to email any of the speakers with your questions. Our contact information is in the slides, and I also wanted to note that there's a copy of the slides on the website. So now I'd like to start it with just a quick overview of several background points. The proposed Part 2 rules were the first proposed revisions in almost 30 years. They were published in the Federal Register on February 9, 2016, and the comments are due on April 11, 2016. Next slide, please. We've identified on this next slide a couple of the different purposes of the revisions. Specifically, we feel that they are to facilitate the electronic exchange of substance abuse disorder information for the treatment and healthcare, and also to allow patients with substance abuse disorders to participate in alternative payment models and in integrated healthcare models like accountable care organizations known as ACOs, as well as health homes. So our objectives of the webinar today are to provide an overview of the revised regulations and where we think that the biggest obstacles lie. And specifically, we think that those obstacles lie in terms of changes to the consent requirements, which we're going to cover in some detail, the definition of what is a Part 2 program, so what are the programs that are subject to these rules, and then issues related to downstream subcontractors. We also intend to discuss the unresolved issues and potential impediments involving the Part 2 rules, where HIPAA and the Part 2 rule intersect and where they continue to require separate attention, and also the operational adjustments needed to prepare for these proposed changes. So now I'll turn it over to Leeann, who will discuss in more detail the proposed revisions to the Part 2 rules.
Well, thank you very much, Rick. And I'm sure as many of our audience members know, these proposed rules had been in place long before HIPAA came out, and they're much more restrictive in many ways with respect to the use and disclosure of information. So they have indeed presented major challenges with regards to the exchange of information and the provision of integrated healthcare, which is becoming more and more reality in the healthcare environment. So these proposed rules are an attempt to address some of these issues. We will talk a little bit today about what they do and also what they don't do, where they might not go far enough. We're not going to cover every aspect of the proposed changes to the regulations today, but instead we're going to focus on the areas of high impact in our opinion. So one of the first issues that we'd like to touch on today is changes to the consent form. And under the current Part 2 regulations, the consent form must include either the name or actually the title of an individual or the name of the organization to which the disclosure is to be made. Under the proposed rule, it kind of parses out different ways and different types of information that must be obtained under consent. Consent can identify either the names of individuals to whom information would be disclosed, the name of the entity if the entity is a treating provider, or if the entity is a third-party payer that requires patient identifying information for reimbursement, again, the name of the entity or organization can be included. But there's also kind of this new category that talks about what can be included on the consent form when there's an intermediary involved in the relationship. So if there's an intermediary that does not have a treating relationship, like a health information exchange or accountable care organization, coordinated care organization, research institution, or similar types of organizations, then the consent form can include the name of an individual participant, or it can include the name of an entity that has a treating provider relationship with the patient, or a general designation of an individual or entity participant or class of participants with a treating provider relationship. And I think that's really the big change, is that there can be this general designation, and that could be something like primary care providers, or providers that provide care. Health homes would not necessarily be the case, but certainly it can be a very general designation with regards to type of healthcare providers. If there are requirements associated with this general designation, first of all, the form must describe the amount and kind of substance use disorder treatment that may be disclosed. So all patient records is insufficient. It has to be somewhat more detailed than that. There are certain required statements saying that a patient may receive an accounting of disclosures, and those are disclosures in particular or to the entities who information is disclosed to under a general designation, disclosure to treating providers. And secondly, there must be a statement saying that the patient understands the terms of the consent. The name of the Part 2 program who will be disclosing the information must be specifically named on the form. Additional operational requirements for consent are that the intermediary basically must have a mechanism to determine whether the providers to whom a disclosure would be made are treating providers. And that could be done by provider attestation or patient portal according to the preamble to the rule. Now, a treating provider is someone with whom a patient agrees to be diagnosed, evaluated, or treated, or there's some type of agreement to undertake such diagnosis, evaluation, or treatment. It doesn't have to be a written agreement. It could be by making an appointment or by making a decision to receive treatment even in the future. But that is something that has to be given consideration. And of course, in an attempt to modernize, the Part 2 revisions also note that electronic signatures may be permitted.
Jenny, from a provider's perspective, do you think that these changes to the consent requirements achieve their objective of facilitating health information exchange and integrated healthcare, or do they continue to impose certain impediments for providers?
Well, one of the biggest challenges, as Leeann said, to the Part 2 regulations for providers is that almost all disclosures of Part 2 information require a consent, and that consent must meet very specific statutory requirements. And as I think Leeann already said, there is no corresponding consent exceptions under Part 2 that there are under HIPAA for treatment, payment, and operations. And this is significant because most of the integrated care models rely upon those type of exceptions when they're taking in records from other locations. With that being said, there are some positive changes that came out of the proposed regulations, namely the clarification that the consent requirements apply to both electronic and written information. It seems kind of like a no-brainer, and most Part 2 programs with EHRs assumed that it had applied to electronic information, but there wasn't widespread agreement on that, and that was an impediment that will be remedied by that clarification. Additionally, the general consent for treating providers may play out as useful. Although to get to true integrated care, it's likely that a similar exception like we have under HIPAA would be necessary. And the reason that I say that is many of these integrated care models that you're talking about have electronic health records that are set up for HIPAA compliance, but not necessarily 42 CFR compliance. And that's the current state that we're in now, with sort of one set of consent requirements under the Part 2 regulations. And EHRs are not necessarily set up for that level of consent. Now we're introducing various levels of consent based upon who you are providing information to, whether it be a third-party payer or another treating provider. And I think that'll pose a lot of difficulties with integrating substance abuse information into these models. There's another thing as well, which is that the patients have the right to revoke the consent at any point. This is different also from HIPAA because the disclosures under HIPAA are allowed without the consent. So the HIEs and ACOs and their EHR systems are going to have to accommodate that ability to revoke a consent. And I see that as an impediment to currently integrating with integrated care models for Part 2 providers, and I don't see that going away as if these proposed rules are implemented as written.
Thanks. Leeann, how do you think these changes impact HIEs and other intermediaries in this data exchange?
Well, I think one of the considerations with intermediaries is that they still have to be named. There's no general designation that is permitted for intermediaries. And I think that as the networks of entities that are involved in the exchange of healthcare information grows, this becomes increasingly complicated to be able to name the HIE, for example, that's going to exchange the information, and maybe the additional network that they contract with, because often in an HIE environment there are multiple levels of networks. There might be a regional network, a statewide network, and even in some cases a national network. So in that context, I think that there are some potential limitations with being able to use a consent model to facilitate the exchange of information through and to some extent the same issue may arise in terms of ACOs and clinical care networks, but particularly I think in the HIE context. Okay. Well, the next topic we'll talk a little bit about is then the application of the Part 2 rules to general medical practices. And in the past, of course, there was some definition and some guidance by SAMHSA that the rules applied to identified units and hospitals and other general medical facilities, but there was still some ambiguity about how it applied in terms of physician practices, or what is now called general medical practices. So now, under these proposed revisions, the definition of a Part 2 program would not apply unless either an identified unit within a general medical facility or general medical practice holds itself out as providing and provides substance use disorder diagnosis, treatment, or referral from treatment, or if the primary function of medical personnel or other staff in the facility or medical practice is the provision of such services and they are identified as providing such services. Now, in the previous, in the current iteration of the regulations, hold itself out is not defined. And so one of the things these proposed revisions do is to add a definition of what it means to hold itself out. And here we note that it reasonably refers to any activity that would lead one to conclude that the individual or entity provides substance abuse disorder diagnosis, treatment, or referral from treatment. They talk about authorization by state or federal government, so of course licenses, certifications of particular personnel, registration, and so forth to provide such services. Also advertisements, notices, or statements that suggest that they are oriented toward consumers to some extent, and consultation activities relative to such services is the third category that is addressed here.
So Jenny, what do you think are the implications of this change?
Well, we've been seeing more and more different type of providers begin integrating substance abuse as an offering into their practices or into their facilities, which is terrific as there are more than enough patients to go around. We've all seen the headlines on the opioid epidemic, and there's been a lot of research that has come out about the amount of people who do not seek treatment or have had access to treatment. There have also been substantial efforts over the years to provide family medicine or other general health practitioners with information to assist them with their patients and families that are suffering from both the physical and mental health aspects of addiction. However, we think that this will actually increase the amount of healthcare providers that will be subject to 42 CFR. The proposed regulations, we've noticed, have caused other providers to reach out to us as an organization to understand how to operationalize these regulations. And a fair number have been a bit shocked by the administrative burden of particularly the consent requirements, noodling out how to segregate the substance abuse information from between their HIPAA-protected information and those that would be subject to 42 CFR. And many are concerned about the changes that will be needed to be made to their EHRs to accommodate their relationships with their service providers, particularly the service providers that provide electronic services, and their ability to accommodate the segregation that is required to adhere to the regulations. And I think many general practices and healthcare organizations that are providing substance abuse treatment as part of their offerings really need to take a hard look at this hold itself out rule. It's very encompassing, and significant changes will need to be made to their administrative workflow, including training their HIM departments on how to recognize 42 CFR information, that sort of thing.
Leeann, a question for you. Do you think providers will be able to easily identify whether they are subject to Part 2 under this revised definition? Do the proposed rules provide sufficient guidance in that regard?
Well, I think this has always been an issue with entities that either may have a dual diagnosis program or maybe they are a general medical practice that in some way interact with patients who have substance abuse disorders. And I think that the rules provide some additional clarification, but again, there remains, I think, certain ambiguities. For example, consultation activities relative to such services are included in the definition of holds itself out, and that could be defined very broadly. If an individual comes into a primary care physician and identifies they have a substance abuse disorder, at what point does taking that information in and making a referral subject the primary care practice to 42 CFR Part 2. Now, I don't think the intent of the rule was to subject all primary care practices or general medical practices to the particular requirements, but there are still ambiguities, I think, with regards to identifying medical personnel and being able to treat individual medical personnel who hold themselves out as providing and are identified as providing substance abuse services. Again, I think that creates some challenges with regards to handling of the records of those particular personnel. So, another thing we want to touch on today is really the rules related to qualified service organizations. And I think one of the really positive things that this rule did was clarify that population health management is a service that may be offered by a qualified service organization, but of course care coordination is not. They do note that patient records can be disclosed under a QSO agreement to the office or unit that's responsible for population health, whether that's in an organization like a health home, an accountable care organization, or other, but that the information cannot then be disclosed broadly within the organization. It only goes to the individuals who are responsible for those activities, and the QSO can't disclose Part 2 program data to other participants in the population health management activities. So the other piece, I think, in the preamble to the rule, there's a reference to the Q&A on contract agents with and their relationship to QSO. So the preamble and FAQs by SAMHSA talk about the fact that QSO may disclose information to a contract agent as necessary to provide services described in the QSOA, as long as the agent only discloses the information either back to the QSO or to the Part 2 program from which the information originated, and further agrees to be bound by Part 2 requirements. Now this particular piece is not actually in the rule, but it is noted specifically in the preamble to the regulations.
Jenny, what do you see as the issues with operationalizing these QSO requirements? What obstacles remain with respect to subcontractors, in your opinion?
I agree with Leeann that we were very pleased to see that the population health was included in a QSO relationship. As you know, the current regulations have some examples of what a QSO is, but those examples are not exhaustive, and they really haven't been updated for an electronic environment. And unfortunately, that was a huge miss with the proposed regs. Many companies have taken a very literal viewpoint of when a QSO is implicated, as opposed to looking at the SAMHSA FAQs on electronic sharing of information, that sort of thing. Operationalizing a QSO relationship is very challenging. And in some areas of our organization, we have not been able to leverage the tools that are available to other healthcare providers, as some of our contractors are not willing to adhere to the Part 2 requirements, which is an essential element of a QSO relationship. This is particularly the case with service providers who are handling electronic information. Particularly in instances where those service providers also utilize cloud storage or significant subcontractors. They've invested a significant amount in HIPAA compliance and therefore would be willing to sign a business associate agreement, but looking at the QSO requirements, which require adherence to the Part 2 regulations, we've had service providers walk away from pretty large contracts due solely to the issue of not wanting to comply with the Part 2 regulations. Another issue remains, as I alluded to a bit, about what do you do with the subcontractors to the QSO? And that really is not very clear for Part 2 programs, and also for those service providers who are also providing services. And I think that was another opportunity that SAMHSA could have taken to really streamline things for Part 2 programs as we live in a much more digital age.
Thanks. Leeann, from the perspective of an HIE, what impediments do you think remain to the exchange of health information?
Well, I think Jenny's touched on, many of the important points, but again, when you look at the role of a downstream subcontractor here, the subcontractor can only disclose information back to the QSO. So if you have a QSO that contracts with another entity, that entity cannot share information under a literal interpretation here with other program participants that might be participating in an HIE. It's not very clear, and I think that the HIPAA rules, again, as Jenny alluded to, have gone a long way toward addressing the roles of business associates and downstream subcontractors, and these rules, 42 CFR Part 2 rules, still do not align with that. So I think we'll just have time to touch on one more topic here quickly. And certainly you can look at the slides for the last few things and feel free to contact us if you have any questions. But the last thing we want to talk briefly about is the definition of medical emergency. Now, what the proposed rules here did was really just to align the definition of a medical emergency with a statutory definition of a bona fide medical emergency. So now patient identifying information can be disclosed to medical personnel only to the extent necessary to meet a bona fide medical emergency. If there's a situation in which prior informed consent cannot be obtained. Now, of course, previously the language of the rule talked about information being disclosed to treat a condition which poses an immediate threat to the health of any individual and which requires immediate intervention. So that's really the key change here.
Jenny, how do you think this revised definition of medical emergency helps a Part 2 program decide when to disclose patient identifying information?
It doesn't change much. This is still very much a judgment call, even with the new definition. Our guidance has been that if the situation is dire enough to call EMS, then go ahead with the disclosure. And practically, this hasn't been an area that has drawn much patient complaints, but it does beg the question of when a consent is actually necessary. Is it when if a patient is alert and conscious but having a bona fide medical emergency, is a consent still required of a Part 2 program, or are we able to provide information without that patient's consent? Consent meaning the written document that we're required to get under the Part 2 rules. And, additionally, does that consent have to extend to both the EMS service, the hospital, the providers, et cetera, or can that just go with the patient with the expectation that it's going to be used for the emergency that it's sent for? Another practical consideration for providers is that in a true bona fide medical emergency, you're relying on staff to be able to discern which parts of the medical record are necessary to go with the patient on the medical or to assist with the medical emergency, and that can be quite difficult for staff. But again, we err on the side of caution practically here at Hazelden Betty Ford.
Thanks. Leeann, last question for you. What are the issues for HIEs with regard to disclosure of information for medical emergencies, and do these proposed revisions address those issues?
Well, I think one of the key issues for HIEs is that they're not allowed to come up with criteria, either be the criteria be provided by the institution or otherwise, to automatically designate certain situations as a medical emergency. It actually has to be the treating provider that identifies whether something is a medical emergency, and then the HIE has to document the name of the medical personnel to whom the disclosure was made, and the nature of the medical emergency and so forth. And I don't know that HIEs are really set up to be able to engage in that type of interchange, so it makes it very difficult to actually operationalize the disclosure of information without consent in an HIE environment, which, as you know, operates different than an EHR, for example, where someone can go in and break the glass. So I think that presents continued challenges, and the change in the definition doesn't really get to those points.
Well, we are out of time, so I wanted to thank everyone again for joining our webinar today. I know we didn't make it through all the slides, but to the extent that there are any additional questions, please feel free to email any of the speakers. I also wanted to just remind everyone that the comments on the proposed regulations, to the extent that you want to comment, are due April 11th. And also please consider taking the survey that's on our website. So thank you again, and enjoy your day.